The question is if
Hello. For two speaker, question: do you recognize stable dislocation of the elbow?
can you clarify?
That means after the reduction, that the elbow is stable and you can start rehabilitation straight away.
That means somebody complained from a dislocation, and we see him later on. So what are we doing if it's stable?
Yeah.
I start immediately the rehab. If it's stable in full extension.
That means there is no other soft tissue injury. Can you believe that exists or not? That you don't have a rupture of medial collateral ligament or associated other injury of the lateral ligament complex, that is only dislocation and you can go on. Does it exist?
For me, no. If you have, it could be a recurrent dislocation. That means somebody who dislocated before, but if you have a dislocation anyway, you need some soft tissue disruption. So you must have an hematoma, whether either on the medial part, either on the posterolateral part, or some swelling or some stiffness. But there is no dislocation reduced without any sign, in my opinion. I don't know.
I have one. Thanks. No, I agree. We agree. We agree on most everything. Here's my take on this. And I think that the Josephson studies have helped a lot in terms of my understanding of this, okay? So when he operated on these patients, their ligaments were torn. All their ligaments were torn. It didn't matter whether they were stable to varus, valgus, or whatever. The ligaments are torn. The only way you can dislocate your elbow is to tear your ligaments. But once it's reduced, it may be stable because there's inherent bony contribution of stability, and then there's also the muscle tone. So you have muscle tone helping to keep it in place. So I think we agree about that. Okay, so we agree with that. And then the question is, forget about whether you do a stress exam or not. The question is when to initiate range of motion. So we agree that they're torn. And so here's my take on it. In the old days, people would be immobilized for a month. And invariably, they got stiff. Melhoff had that great paper where if you immobilize patients for longer than 2 weeks, they have permanent stiffness. Then the pendulum, to some degree, swung all the way the other way to start immediate motion. And concurrent with that was the description of posterolateral rotatory instability, that these patients, maybe they're moving too early because they definitely have ligament tears. And so maybe somewhere in between is best. And so that's what I do. Even if their elbow's totally stable, I immobilize them, I would do it. You got to tell me what you did for your own elbows. Well, I guess by necessity you had to move your elbows, right? Yeah. And so I say somewhere between about 10 days of immobilization, and then I have them move it. But that's knowing that all the ligaments are torn.
Well, not so far in this case, because when I say you mobilize the elbow immediately, when I test it, I just look at where the range of motion, the risk of instability. But 10 days or 0 days is the same regarding the risk of loosening of the healing. So you just have to protect, the range of motion which is at risk. If you have some rotatory instability, I'm fully agree. For your last lecture, it was perfectly right for me for the chronic instability, because it was patient who complained from something and you find a rotatory instability, so you have to rebuild something on the lateral side. But in acute cases, in my opinion, this part of the ligament, which is a thinner one among all the ligament around the elbow, if you let it heal spontaneously like you did for an ankle or for other place, it will heal spontaneously. I agree with you, there is posterolateral instability. It exists for sure, and it's obvious. But for most of them, you don't need to repair it because it will heal spontaneously. So you can make some rehab, protecting the supination if the patient has apprehension in this position. That's my way to do it. That's why I rehab immediately.
Right. So I have two more points. One is the dynamic contribution to stability, and I'll make an analogy. So you have a shoulder dislocation, and you get an X-ray post-reduction, and the shoulder's a little low. right? It's reduced, but there's a little subluxation, inferior. Now, would you do a stress exam? The shoulder was dislocated, you put it back in joint, now you get an x-ray and it's a little low. Would you get would you do a stress exam?
You can compare it.
No,
The shoulder is fully unstable naturally.
Okay, it'll be unstable.
And the elbow
if
is conversely, it's fully stable.
So that's number one. Number two is occasionally you'll find a simple dislocation where after you reduce it, there's a little sag in the ulnohumeral joint. And I think what happens is they have some muscle inhibition. They have muscle inhibition, their elbow's sagging. That doesn't mean they're going to be unstable. When they come back to the office the next week, you get an x-ray and it looks totally fine. So I think that it's unfair to make an assessment based on that initial examination of what the ultimate will be, because oftentimes they'll recover their tone and then their elbow will be much more stable. The other half of that, so I had a patient recently, it's kind of enlightening. So she's a transplant patient, she's in her 60s. She had a simple dislocation. Her elbow was examined, reduced by the residents in the emergency department. They did an arc of motion. It popped out, kept popping out at about 30 degrees. They splinted her. She, in the splint, said, "I feel like my elbow's sliding out." And so I got a CAT scan. Okay, I got a CAT scan, and there's nothing in the joint. And the joint was totally congruent, not sagging, nothing in this. We immobilized her in pronation for a couple of weeks, and then with an extension stop, so gradually allowed her more extension. So the treatment was definitely tailored to the findings of her examination, if you want to call it a stress exam, and she did fine. So I would think that you and I both agree that most simple dislocations don't need surgery.
Perfectly right.
Do you ever operate on simple dislocation?
Most part of them.
Right. So this is when it gets complicated by a fracture, and then the only question is, do we differ in our algorithm of treatment? So I learned from the Mayo Clinic, you always start from the lateral side, lateral collateral ligament, radial head, either fix or replace it, coronoid, and then medial collateral ligament last.
And that's why I differ from you, that I think there is not only posterolateral rotatory instability, there was also valgus instability, real valgus instability, without lateral disruption or with slight stretching, I should say, and most of them are stabilized when you fixed it medially. And in my opinion, and especially in athletes, when I dislocate both my elbow on the left side, I had a radial fracture, and my friend told me, what I gonna do if I don't allow you to put me a prosthesis anyway. Yeah. You remove the radial head if it's not fixable, but you don't put me a prosthesis, and he didn't. So
did you have it fixed?
Yeah, it fixed it some. Partially.
I would side with him. I mean, he's got a compelling argument because he had this problem himself.
What do you do when you have a real unstable inside the plaster? You go to the patient comes to the emergency department. You reduce the fellow, they reduce not the fracture, the dislocation, and then they put the plaster. And in 4 days, you take a new X-ray, and it's completely locked again. What do you suggest to do?
Yeah, in the X-ray, there were X-rays that showed it to be reduced.
The X-ray immediately they showed it was reduced. After 4 days, it's completely gone.
Yeah.
90 degrees of flexion.
Yeah, I would want to know, are there any fractures associated with it? Not at all. Yeah, that's one that I might operate on.
Me too, because for sure, in my opinion, the anterior capsule is inside, is a joint line.
That was my question. And I tell you that if you read Bernard Murray's book about dislocation, he said that writing the book, when he started to write the chapter about chronic dislocation, not chronic redislocation, chronic dislocation, he was asking to some friend from outside United States because they do not have any real chronic luxation. In my experience, in my country, up to date, myself and 3 different other doctors, we got 12 cases of chronic dislocation more than 6 months because of this. Because they have reluxed in the plaster, maybe they didn't do a new X-ray after a week, so they do after 45 days, and everything was gone. So you have to open everything and put a internal fixator.
Excuse me, Dr. Cassidy, can we just go back to the pathanatomy? You mentioned that the type of injury is a rotary one, and it's it started with the tear of the LCL, and then the radial head will move. Just I have one theory, and it's a question, in fact. Now, why would we see the LCL is stripped from its origin? It's like you are using a periosteal elevation and elevator, and you are stripping it. So my question and theory about it, I think the radial head will go out of its place, and what's in the front is the LCL, and it will just keep on pushing it and strip it away, and then this will continue the rotary action and the injury to the other components. I don't know how would you comment on that?
In accurate cases.
In acute cases, yes.
Yeah.
When you open on, you'll see it always is stripped, and even the photo you show us, it's stripped from its origin.
Sure, yeah. Yeah, I agree with
In
that.
acute cases, I don't know how many cases when we open, how many cases we'll see it torn in the mid-substance.
Yeah, it's infrequent.
Most of it, it's stripped
away
away with
yeah.
the muscle organ.
No, I think you're right. Sometimes the common extensor tendon is still intact, and those fibers, the lateral collateral ligament fibers that go to the annular ligament, remain intact. But the head, it drops out, and it peels off that part of the capsule, including the ligament. I agree with that.
Just a comment about that. I can answer properly because I don't operate them, as you understood. But of course, you can imagine that when you have a posterior dislocation of the radial head, you need a posterior bundle of the LCL disruption. You need it. You can dislocate without it. But in my opinion, probably it will leave spontaneously for most of them. So that's for most of them.
Actually, I have a comment and one question. About the immobilization of the elbow. I came from place, Hamad General Hospital. We have a lot of trauma, and every call there is maybe 2 or 3 complex or simple elbow dislocation. I noticed if I do immobilization for 1 to 2 weeks for a simple dislocation elbow, the patient come to me in the clinic after removing of the plaster with painless, less swelling, and he can do some range of motion.
You remove it by
Yeah.
yourself, or you?
No. Just I will do immobilization with the plaster, above elbow plaster, for 1 to 2 weeks, and I see him in the clinic. After 1 to 2 weeks, I remove the plaster. I notice the swelling is much less. Of course, the soft tissue ecchymosis and these things also less, and he can do some range of motion. If I just put a cuff and collar and tubic rib, and I told him to do some range of motion, he'll come to me in severe pain after 1 to 2 weeks. We're talking about simple dislocation. He'll come in severe pain with really stiff elbow, and he's not doing any range of motion.
Not by experience, but why not?
This is just a notice from. And I have a question. When you do fixation of the displaced coracoid process, coronoid process, you will do from posterior approach or lateral?
I will do arthroscopically.
Okay.
I do it arthroscopically. That means I make my 2 portals anteriorly, because you see exactly the fracture. You know the tip of the coronoid process is intra-articular, is not extra-articular. The capsule just is attached just under. So when you get in, you just remove the hematoma with one retractor, one with one instrument, you push it again the trochlea, that means you reduce it, so you push it away. From posterior approach, you put one drill guide and you go straight in the fracture site. So when you just appear at the fracture site, you push back the fragment with the spatula and you go straight in front and you screw it.
Okay, if I cannot do arthroscopy.
And how do you put it? How do you put this screw from anterior to posterior?
If I can't do close any reduction by KOR or whatever, I can put posterior to anterior.
Yes, of course, you
If
do
not,
it by posterior to anterior. After
Yeah.
the control can be made arthroscopically or can be made open.
But if it's big piece and need to do open reduction, real reduction, sometimes you have to open lateral or medial.
Doing arthroscopically, it is quite difficult. Well, I tried a couple of times, but I go from medial side.
Yeah.
Medial side.
Medial side and screw over from anterior to posterior.
Yeah, I actually have a talk on that. It's pretty quick well, we'll see. But you can go maybe 4 approaches. You can go from the lateral side if you take the radial head out,
Yeah.
if it's a relatively small piece, because now you have plenty of room. You can go from posterior, so sometimes if you have like a posterior Montague fracture that has a separate coronoid piece, you put a plate on the back, and if you flex the elbow all the way up, the coronoid reduces in the coronoid fossa, it locks in there, and you could put a screw right, now it's locked in, you put a screw right through it. But if it's a real piece, I'll go medially and fix it. And I use a plate because I feel like it's a shearing fracture, it needs a buttress plate, I put a plate on it.
Thank you.
Sure. Good.
More question?